Good morning. My name is Dr. Don Klitgaard. I'm a physician faculty with the Iowa Healthcare Collaborative supporting the SIM project, and just wanted to bring some information to you today about risk. Risk is a topic that's come up in healthcare, and we're going to spend a few minutes just doing an overview of risk. How does that work? What is it in this setting? What's important to understand about it? So the main objectives of today's discussion are going to be to review a few of the major drivers in healthcare, what's going on in healthcare nationally in the big picture, and how these changes that are going on have led us to have an increased emphasis on understanding risk. We're going to dig into and try and understand what's meant by that term in risk when it's applied to healthcare in 2018. And specifically some various types of risks that healthcare organizations are likely to encounter. We'll differentiate between some of those and talk specifically about actuarial risk or risk scoring, contractual risk, risk management, and risk adjustment, and what's different about those and why they're important to understand in our practices in healthcare and our communities in healthcare in 2018. As you likely know, there are incredibly rapid changes that have been occurring recently in healthcare delivery in the last 5 to 10 years. There's probably been more change in healthcare delivery than there has been in a short period of time, maybe since Medicare was first started back in the late 60s, or a few of those kinds of changes. And many of those delivery system changes you may have heard about or been part of or had be part of your practices or your communities. The patient-centered medical home, PCMH, has been a conceptual change around how we provide better, more high-value patient-centered care. It's certainly more of an emphasis on technology, electronic prescribing, using electronic health records, using technology better in the medical world and in healthcare. Telemedicine is an extension of that. If the services can't be provided locally, can we do something with telemedicine? Looking at populations of patients, so have it not just be about one patient that comes in with one complaint and we deal with that and send folks home. That's still very important, but how do we look more broadly at taking care of the populations of patients in our practices and our communities in a little more holistic and broader way? Disease registries, do we know who all the people in our practice or our community are that have diabetes or congestive heart failure or those specific things? And do we have resources in place like health coaches and chronic disease management and care coordination in our offices to help patients to stay healthier, to help improve the care of their chronic conditions if they have those, and also to stay healthier and prevent those whenever possible. Obviously, in the bigger world, there's things like concierge medicine or direct primary care, some different models of providing medical care that are different maybe than our traditional practice model, that are also kind of challenging. How do we deliver care the best? Concurrently, at the same time, we've got a lot of incredibly rapid changes occurring in healthcare payment, right? So if you're part of a medical practice, you may get a per member per month, a certain payment from a payer for taking care of a certain group of people. There are other codes that Medicare CMS has put out there around transitional care management or chronic care management to try and encourage practices to help with the transitions from the ER or from the hospital back into the outpatient world, or to help provide extra services for folks with chronic diseases other than just paying for when that patient is in the office. And so thought processes of what do we need to be doing to keep people healthier, and some payment opportunities that kind of try and match up with that, or some blended option of those. The risk stuff starts to come more into play when we start to talk about things like ACOs. So there's different types of accountable care organizations, or ACOs, out there. There's Medicare Shared Savings Program, MSSP ACOs, a program called NextGen, which has more risk involved. There's other commercial insurers like Blue Cross Blue Shield, Walmart here in Iowa, that has commercial ACOs. Other ways to look at paying for care differently, Medicare and other payers are looking at bundled payments. Do we pay one fee for a knee replacement surgery, and look at kind of bundling all of the costs associated with the preoperative care, the surgery, the postoperative care, all in one big payment. And there are more and more what are called risk-based contracts. So through Medicare Advantage, through Managed Medicaid, through other insurers, and even through Medicare now, some risk that we'll talk about a little later about if you do a good job, there's some upside risk. If you don't do such a good job controlling costs and providing high value care for your patients, there's some potential downside financial risks for practices. One of the biggest things that's happened in the last year and a half to 2 years is the MACRA legislation came out. That was some national legislation that changes how Medicare is going to pay for healthcare going forward. There's some acronyms there. MACRA was the legislation. The Merit-Based Incentive Payment System is MIPS, and the Quality Payment Program is how they've decided to structure all of this. Basically, every physician in the United States that provides services to Medicare patients is going to get a score, a quality score, and going forward, payment is going to be tied to that quality score. And so that is obviously a game changer in a lot of ways. There's a lot of practices, including almost every practice in Iowa and the Midwest has lots of Medicare patients as a big part of their patient base. And so when you start to pay differently for a large percentage of patients like that, it gets everybody's attention and makes you think quite hard about what kind of care you're providing and how we do that. As we look at what's driving this idea of what's called the triple aim, so better care for individual patients, better health for populations, for everyone as a whole, and smarter spending, lower cost through quality improvement. Those are really the fundamental things that were put out there and have really been taken and figured out. How do we do that? How do we provide that better care? How do we spend our healthcare dollars more smartly to get more things out of it? And then there's the concept of the quadruple aim, because if you build this stuff, but you do it in a way that burns out your providers, your physicians, your nurses, your folks in healthcare, and you don't do it in a way that's sustainable, then that's not going to work very well. And so the quadruple aim includes clinician experience to try and make sure that we're making this better for patients and the system, and we're actually making this a better system to provide care in at the same time. The biggest trend behind all of these things is the concept of value, and then of tying value to payment. And when we talk about value in healthcare, that's usually talking about quality in some way, shape, or form, outcome, safety, service, better quality, and lower cost, some combination of those, right? And so it's not just about controlling costs and not doing things so that we save money. It's not just about doing the highest quality care no matter what it costs, and you know, but kind of having a balance of those, right, where we're trying in all cases to improve the quality of the care that's provided, while at the same time holding the cost steady or lower, and trying to improve things so that we're increasing that value proposition. We're increasing the value of the care provided. Medicare looks at it this way, and since Medicare is one of the main payers in the country, and a lot of the private insurers then use Medicare's thought process and you know, payment models and that moving forward, we have to pay a lot of attention to what Medicare is thinking and doing. And this is a Medicare produced slide to kind of let you know what their goals are over the next few years in payment for healthcare. So it's a little complicated. I'll just walk you through it. The left-hand side says current state. So that's sort of where we're at right now. So that big orange bubble is where a lot of Medicare payments sit right now in fee-for-service. So if somebody comes in and is seen in the office, the bill is turned in and they get paid X number of dollars for that specific patient visit. That's kind of fee-for-service, just as it's always been. When you move to the right, then things start to change a little bit. That category 2 is fee-for-service, but with some tie-in to quality and value. And you're going to get paid fee-for-service, but you have to be more accountable for the value of the care you provide. When you move into category 3, they talk about alternative payment models. So things like those accountable care organizations, where it's kind of that fee-for-service stuff, but now you got to be more accountable than ever for cost and you're going to get paid differently for it. And category 4 is moving towards that population-based payment that at some point, you know, man, we may not get paid so much for the visit day-to-day visits, but more for taking care of a whole population of patients in an effective way. And so you can see if that's the current state and how payments are kind of distributed across those different categories right now, where Medicare is wanting to go is they're wanting to move physicians and hospitals and communities and practices to the right. So less fee-for-service with no tie-in to quality and value. There may always be some of that, but it's going to shrink substantially, and more and more of the payment is going to get driven upstream to that population-based or alternative payment models where you have to think more about higher quality and lower cost, and your payment's going to be tied to that. So that's the CMS goal of this payment reform stuff: better patient-centered care, more accountability, more innovation, more trying to provide better care in those ways. So how's all that stuff fit together? This little word picture is kind of what I was trained in medical school, what most healthcare professionals are pretty comfortable with. These are the kind of things that when you go into healthcare, you're used to dealing with, and your education, your training prepares you for in large part, right? All these different words you're used to medicine in the context of labs and tests and diseases and seeing people in the clinic and the doctors and nurses and other professionals and those things. These are pretty common, comfortable words and the way we're used to thinking about the care we provide. Increasingly, though, these words start to get thrown into the discussion, right? Value-based payment is that big one there. So that's what we've just been talking about, how healthcare is paid for, increasingly being tied to value and how well is that care provided and what kind of value does it derive. You can see a lot of other words. A couple of the big ones in there are what we're talking about. The rest of the talk here in risk. Risk is something that we increasingly are going to have to think about and understand. And so we're going to dive deeper into that. And these kinds of transformational types of things in healthcare, both on the delivery and the payment side, are new thoughts and concepts and ideas for a lot of folks in healthcare that we just have to start to educate ourselves about and get more and more comfortable with and understand better if we're going to provide the kind of healthcare we'd like to provide and be successful moving forward. So let's talk a little more about risk, which is kind of the title of the talk, right? So how does it fit in? Why should we care about it? We're increasingly hearing out in the world that we're going to have to take on more risk in healthcare. As providers, as clinics, as physicians, we're certainly hearing that as you better understand risk, you're going to have to take more risk. That sounds kind of scary, but what does that really mean? So we're going to break it down a little bit and see how that term risk is used. There's kind of traditional risk management. That one, most practices, physicians, administrators, are used to hearing about risk management in the setting of malpractice risk or adverse event risk exposure kind of stuff. Then there's a different kind of risk that has to do with contracts. As we start to be paid differently by Medicare and by other insurers, then there can be some upside risk if we do a good job and some downside risk if we don't do a good job in some of those contracts, either in an ACO or in some other kind of value-based purchasing. That's what VBP stands for, their contract. So we might start to get paid differently and have to understand that type of risk. Actuarial risk is looking at healthcare costs across different disease states or different populations of patients. There's lots of actuarial work done in all industries, including healthcare. And if somebody has 1 or 2 or 3 chronic diseases, how does that change their risk and the associated costs that might be associated with taking care of that person going forward? This is something insurance companies have done a lot of. That's what they're based around. We have to start to understand that more in the provision of healthcare. It's not going to be our job. We still have insurance companies to do that part, but we have to more and more understand what that means and how it works and how that affects us. And then the extension of that is risk adjustment, which takes that actuarial risk or risk scoring kind of stuff and then starts to tie payments to it. Okay, so how does that work differently from a payment standpoint if risk adjustment is being used? So in summary there, we don't really need to fear risk, but we do need to spend some time understanding it and what it is and when it's used, how it's being used as we're talking about these different types of risk in healthcare moving forward. So let's do just one level down and kind of take each of those types of risk and look at it just a little deeper so we're sure we have a good understanding of it. So traditional risk management was that first one. And again, this is probably something that's not new to most physicians or practice leaders. And it has to do with the probability of something bad happening. So a specific adverse event occurring either within a specific time frame or within a specific situation. So what's the risk of somebody getting a urinary tract infection if they're in the hospital? Or what's the risk of somebody getting pneumonia after a surgery, or those kinds of bad things happening, right? The clinical risk or healthcare risk is more of a chance of that adverse outcome happening from a treatment or patient care, like we were just discussing, right? So the risk is the adverse event of any kind. The healthcare risk is more like we were just describing, with something bad happening as a result of patient care or treatment or something we're doing, right? And so traditional risk management usually centers around things like identifying high-risk situations where patients could be harmed, implementing some kind of program or intervention to make sure that that doesn't happen. So maybe you have folks use a different process after a surgery around the airway management stuff to keep them from getting pneumonia, to prevent that pneumonia from happening, because you know it's more likely to in that setting, right? And then if that does happen, you have a process in place so you know it happens and you follow up on it and you make sure it doesn't happen the next time, type of thing. So that focuses on patient safety, avoiding adverse events, both for the health of the patient, and then also, you know, in reality, they have healthcare entities have to minimize any financial risks, either directly or indirectly, as those can pose to the healthcare system as well. So it's about keeping people healthy and preventing some of those financial risks, right? So this kind of risk management is probably, of the four types we listed above, it's probably the one that people understand the most deeply. So what's actuarial risk or risk scoring? So this has more to do with setting, in this setting, to be the relative risk of health risk of individuals or populations. Lots of times we've talked about it in terms of severity instead of risk in the past. So how severe might this the health of this patient be, right? Lots of times when we talk about populations, we'll also use terms, and insurance companies especially will also use terms like case mix or sickness or intensity or complexity, comorbidity, health status, those kinds of things, right? And depending on whether you're a healthcare provider or maybe you're a policymaker that's making decisions or laws around healthcare payment, or you're an insurer that's thinking about how you pay for this, or an actuary, some of those words are used more in one setting than the other, but they're all talking about health of population and how you can quantify the health of an individual, and then by extension of a whole population of folks that you might be caring for, right? So in general, that risk scoring is sort of the first stage of adjusting for different levels of risk. So if somebody has, say, diabetes and congestive heart failure and the COPD, they have three pretty significant chronic health conditions, they're going to be at higher risk. They're going to have more severity. They're going to have more comorbidities and be more complex, and therefore probably be expected from an actuarial sense to cost more to care for in the next year than somebody who is either healthy or only has one of those three chronic diseases to deal with. Because the more of those you have together in an individual person, the more complex the care is, the more likely that something might happen to kind of throw them off their balance and wind up with some kinds of health issues that are going to be they're going to make them less healthy, and at the same time increase the cost of care for that patient. So understanding these different subsets of patient populations starts to become important, right? So as we as physicians and practices think about caring for the patients that are under our care, we have to think about how do we use our resources and what approaches do we have in place to manage and help those folks that have more complex conditions and healthcare needs to stay healthy and do a better job with that from the practice side of things. So that's where the kind of the risk scoring or actuarial risk comes into play. If you think about it in terms of something like this, it's a fairly complicated thing here, but it's really simple in its concept. On the left are people that are pretty healthy, very low risk. On the right are people that have lots of health conditions and are fairly complex, right? So as you move from left to right, there's increasing health risk, you know, and so lots of times if we don't do a good job caring for those folks, those green arrows at the top are what happens, and people move from the left to the right. What we want to do is figure out how can we do a better job and provide higher value care to our patients so that they stay where they're at, or like the dark blue arrows on the bottom, they move from the right of this diagram to the left, from more higher risk, complex problems to more simple problems or a healthier state overall. So that's just what this is talking about. But that thinking about populations and risk is sometimes a new way of looking at things for practices. We've been cultured lots of times and trained and organized in a way that we look at what comes through the door and we help take care of that person at that time, where this requires us to sort of step back and look a little more broadly at the populations that we care for. So at this point, you may be feeling like this. So this is just a reminder that don't give in. Don't stick your head in the sand and say this is too complicated or you know, I just don't want to even think about this stuff, because it's important stuff. And once you work through it the first time, it becomes easier and easier and easier to understand and just be kind of part of what you do and how you think about things. So don't give in to this. We'll keep moving forward. The third type of risk was contractual risk. Okay, so risk kind of associated with contracts, because as payment changes and we start to enter into more arrangements where we get paid based on the value of the care we provide, so that's what they mean by value-based payment, then there's agreements or contracts that kind of set the terms of that. And so there's a type of risk that we have to understand when we enter into those agreements. Lots of times we think of those as upside risk and downside risk. And by upside risk, lots of times you think of that as the carrot that's hanging out there. If we do a good job of caring for a group of patients, the payer is going to reward us for that care, that better care, you know, with some type of upside, some type of improved financial return for providing higher value care. Okay. Downside risk is just the opposite. You know, if we, under the terms of that contract, don't do as good a job providing high value care, so we either provide lower quality care and we don't meet our quality thresholds that we maybe have set out, or the care that's provided costs a whole lot more than it was supposed to cost because we haven't managed things very well, then we may be at risk or on the hook for a portion of that increased cost. And that's what's thought of or termed downside risk. A lot of times when we start into doing value-based payment, most physicians, hospitals, doctors, you know, everybody doesn't really want, they're pretty what's called risk averse. We don't want a lot of downside risk. We're not sure we understand this well enough to feel comfortable accepting any downside risk. So a lot of the initial work in this realm happens with an upside only contract, where if we do a good job, say we generate some shared savings that costs less to care for that population than was anticipated, a portion of that savings can flow back to the practices, right? As we move down this road, there may and will be more downside risk kind of creep into some of those arrangements. So ACOs are set up around that idea. A lot of the Medicare Track 1 ACOs mean that if we do a good job, we have that upside only potential. If we don't do a good job, we're not out anything. CMS, Medicare is not coming and asking for repayment of anything. And we get some time to figure this out and to understand this better without being at any specific downside risk, right? There are some CMS or Medicare ACOs, such as the next gen group of ACOs, which have downside risk. They're for people that feel more confident and comfortable in managing this kind of stuff, and they have a bigger carrot. They may have, if they do a good job, they may get a much higher percentage of the shared savings, but if they don't, they're also on the hook for some of the downside, okay? Commercial ACOs kind of fall into that same category, where a Blue Cross ACO or another payer's ACO, lots of times we'll have a mixture of that upside risk, sometimes upside only, or some downside risk. And so understanding how that works and what the components of those upside and downside risks are and the criteria around them are important. And that's a whole separate talk. We're not going to go there today. I will mention the concept of full capitation because that word comes up a lot. Some of that was tried back in the 90s, somewhat unsuccessfully because it wasn't tied very well to quality. But lots of times people will say that where we may well end up with this 3, 5, 10 years down the road is something more like full capitation, where we get paid a certain amount to take care of that group of people. And if we do a great job, we'll do a whole lot better financially, as long as we meet all the quality targets and we're doing a good job from the quality standpoint as well. But if not, we're at significant downside risk for that as well. Now, most parts of the country, certainly in Iowa and the Midwest, there's not a lot of full capitation. There are some parts of the country, some Medicare Advantage plans and others that are much closer to that today. Often that's on the coast and places where this stuff has been going on for a lot longer than it has here. So just to kind of put that in a diagram perspective, if you look at increasing amounts of risk, and again, this is a Medicare slide, but it applies across the board, and lots of times what Medicare does, other payers do. So the low risk ones on the left, that's traditional fee for service or the track one-sided, kind of upside only kinds of models. As you move forward, as you move up this to the Medicare Advantage full capitation end, there is an increasing amount of risk across that spectrum. So that's why it's important, because this is really CMS's idea. CMS's goal is to move people slowly up that, from left to right, up that model of assuming more risk in how they get paid. So again, it's not going to happen tomorrow. We don't have to, it's not going to be we got to jump off a cliff tomorrow kind of thing without knowing what's going on. But it is an understanding and a skill set we need to develop because of that. The last concept we're going to talk about is risk adjustment. So that's another term of risk. Payers use risk adjustment to set budgets, to basically figure out for a group of patients. They do the actuarial risk or the risk scoring that we talked about, but then they start to tie specific dollars to it and adjust up or down budgets for the next year on how much we think it's going to cost to take care of that patient or that group of patients. That's how the insurance companies on their end figure that out, right? So they use this risk adjustment. How that ties directly to us is that risk adjustment in large part is based almost solely on the codes that physicians and practices submit on a bill to that insurer, all right? So they do look at demographics, they do look at the age and the gender of whatever patient or from their standpoint beneficiary they're talking about. But the majority of how that risk adjustment happens is based on what we as providers tell the insurance company about that patient, all right? So they're not going into our EHRs, our clinic charts, and looking at diagnoses and how sick somebody is and that. What they're using from their standpoint to say this is a pretty complex patient that's probably going to cost a lot to care for next year or not is almost solely based on what codes we put on our super bills and turn into Medicare or Blue Cross or whatever payer we're talking about. Now, in the past, that's always been the case, but in the past, we haven't had to think about or worry about the budget or what it's expected to cost for that patient next year. That was just the insurance company's work, right? As we move into this realm of value-based payment and ACOs and moving towards full capitation, we have to start to understand those costs better. And an important part of that is understanding that if we do a good job coding on our side, then the insurance company can do a much better job of predicting the cost of that patient going forward. And that's going to be important to us because if they do a good job accounting for that potential cost, then we are going to be much more successful on the shared savings side of things. And that's, again, a whole nother talk that we're not going to dive into deeper today. But I want you to at least have an understanding of that concept of coding has always been important in our fee-for-service world, you know, to make sure that we're billing appropriately for a certain level of service. It becomes even more important in the value-based purchasing world because that's what the payers, the insurers use to set the budgets and set in all honesty, set the targets for us so that they're going to use to evaluate whether or not we did a good job managing the costs for that patient or that population. So lots of complexity in what we just talked about risk. I understand that. And we gave you the overview of those different components of risk in healthcare. When you're struggling to understand that and thinking about that, remember all of this stuff is an ongoing process. Whenever we change, and in this case, the change has to do with our understanding of value in healthcare and being paid differently for value in healthcare and how risk plays into that complexity of healthcare delivery and payment. This is a process, and it's going to take years for us to gradually understand and become aware of all the complexities of this. So don't be overwhelmed. Take it a step at a time. Continue to learn more, and I guarantee you, as you think through it more and more and more, it becomes much more understandable, much more clear, just a natural part of what we know and what we do in healthcare. So if you have any questions, my contact information is listed here. Feel free to reach out. I hope you have found this session useful, and I look forward to talking to you again another time. Thank you.